All right, and we are live.
Awesome. All right, everyone, welcome to another edition of We Good, the virtual town hall about COVID-19 data and defunding or dismantling the Minneapolis Police Department. My name is Brittany L. Wright, and before we get started, I just want to start off by thanking our sponsors. The African American Leadership Forum has put this forum together thanks to the generous support of the Minneapolis Foundation, North Point Health and Wellness, and Children's Minnesota. Also, we want to thank our partners, North Point, Children's Minnesota, Insight News, the Minnesota Spokesman Recorder, and Minnesota Community Care. So today's virtual town hall is part one of a two-part series. And today we'll be focused on data, specifically around COVID-19, and also about the hot topic of defunding the police. Our conversation will conclude during our next town hall as we take a deeper dive into COVID-19 and defunding the police. So I just want to set that note that this is not going to be a complete conversation, but what we're going to do today is kind of set the scene and the context for what will continue to be discussed over the next few weeks. Joining us today is our expert panelist. Up first, we have our guest healthcare provider, Ms. Adrienne Thornton, who is a nurse and infection preventionist at Children's Minnesota. Welcome, Adrienne. Also joining us is Dr. Gilliam, who is a family medicine specialist at North Point Health and Wellness. Welcome, Dr. Gilliam. Also joining us is Rebecca Lucero, who is the Commissioner of Human Rights at the state of Minnesota. Welcome, Rebecca. And last but certainly not least is Tanya Gladney, who is the University of St. Thomas Sociology Criminal Justice Program educator, and she's going to be breaking down all things sociology and criminal justice towards the end of our conversation. But up first, we always want to set the scene, being reminded that despite all of the things that are happening within our community, we are still in a global pandemic. So I want to kick off the conversation to Ms. Adrienne Thornton, who's been doing the work at Children's Minnesota to not only make sure that our young people are safe and healthy, but that we're preventing the spread of COVID-19. So Adrienne, I want to pivot to you. What does the data say about COVID-19 today? Are we doing better as a state? Are things getting worse? And how specifically are Black Minnesotans being impacted?
That's a loaded question, and good morning to everyone. Thank you for having me. What I'm going to do now is I'm going to share with you the data from the Minnesota Department of Health, just kind of showing where we started and where we are now, and a little bit of a deeper dive into the impact on the different races and ethnicities. So I will share with you now the data. And if you have questions as I'm going through this data, because I do know that sometimes data can be a bit daunting, please post them in the chat and I will answer them as we go along. You do not need to wait until the end because I do want to answer your questions as we're going along. And again, I work for Children's, but I am presenting data that is developed and distributed by the Minnesota Department of Health. You can find these graphs and data on their website if you want to see it for yourself. And what I'm presenting is their weekly summary. And the weekly summary is a little different from what I've been presenting in the past. In the past, I presented the most recent data from that day. And so for the weekly data, it takes a little bit longer for them to compile the data and create the graph. So this is from last week, from June 11th. And so, this is the first graph. This is just a general overview. So looking at the cases from start to finish, the first thing you need to know is that when we look at data as epidemiologists, we look at the week of the year. And so at the bottom where it says week 10, week 11, week 12, and thus far, that is the established week in the year. There are 52 weeks in the year, and the first week generally starts in January. Sometimes it starts at the end of December, but for the most part, the first week is in January. So when you see week on there, just know that is the week in the year. And so the data for COVID started to be compiled during week 10, which was March 1st through March 7th. Now, keep in mind, they may add data to this as we go along. Once we get to a point where it's not quite as intensive as it is now, they very well may add data going back to January, because that will require a little bit more investigation and looking at samples and clinical records. But right now we're starting in March. The surveillance period actually covers January through the end of the year. And so we started doing active surveillance in week 10, the week of March 1st. And as you can see, we weren't really seeing any cases, but by the beginning of April, we quickly saw our number of cases go to a really quick incline. The deaths didn't really start to incline until about week 19, where you see a little bit of a bump up, and then it gets, fairly large during week 24, which was last week. But just look at that line for the number of cases. We really saw the biggest increases right here in the beginning of May, and that was after we started with the shutdowns and people staying home. And so what you'll notice is that we're starting to see a bit of a plateau right here. And I honestly can say that, the plateau is because people were staying home and they're wearing masks and they're doing their hand hygiene and they're doing takeout food instead of eating in restaurants. And so it works. It took us a while to get to this point because we started, I think, back here in week 18 with, the starting to shut the state down. And it took us a while to get to this point, but we are finally getting to a point where instead of increasing numbers of cases, we're seeing fairly the same amount of cases. Now, this is a graph, and I love this. I put these side by side just so that you could see the comparison. So the first one is the number of laboratory tests that were actually done. And so you can see that starting here at the very beginning, we were doing less than, I think, 10,000 tests a week. And so it slowly increased. And of course, as we do more testing, you expect to see more cases. Well, what you see here is that we continue to increase the number of tests that we're able to do or that we're doing. But again, on this graph, you see that we start to plateau just a little bit right here, even though we're still increasing the number of tests that we're doing. We're not seeing an increased number of cases, and that's good. We want that to happen because what we know is that when you go looking for something, you find it. So we knew that as we increased the number of tests that were being done, we were going to see more cases. What we want to happen is that we're doing more testing, but the number of positive cases isn't increasing because we're having less transmission in the community. And then this looks at hospitalizations, including ICU. And I like this graph because even though we have a lot of people that are hospitalized, the ICU numbers aren't as bad as what we think. Now, here's the kicker. This is about 1,000 ICU beds being used, and we don't have much more than that in the state. So that's the problem. It's good that we have fewer ICU cases. If you think of New York, they ran out of ICU beds. We don't want to get to that point. So it's good that there's a big divide between the number of hospitalizations and the number of ICU beds being used. But we have to keep an eye on this. It's still a concern. But as you can see, both of these are starting to plateau as well. So that's good. We're testing more. We have a lot of positive cases, but the number of positive cases are starting to plateau. The number of hospitalizations are starting to plateau, and the number of people requiring ICU level care is starting to plateau as well. So we're going in the right direction. This is looking at the demographics by age, and we've talked about this every week, that the highest number of cases, of positive cases, is in these two younger adult age groups, 20 to 29 and 30 to 39. Unfortunately, the percentage of deaths are higher in our older population. And so I have to reiterate to our young people, my daughter is in this 20 to 29 age range. And I am constantly reminding her that we are still in the pandemic. It's getting better. But what happens is this age group gets it and they give it to this age group. And these age groups suffer more. They don't get really sick when they're 20 to 29 or 30 to 39. If they require hospitalization, they're not requiring a lot of ICU beds. As you can see, if you look at these green bars, hardly any of the 20 to 29-year-olds are requiring ICU level beds, and less than half of the 30 to 39-year-olds. But then when you get to our 70-year-olds and our 60-year-olds, they're requiring a lot of ICU beds, and our 50-year-olds, which this is where I am, so I hope I don't get it, but they're requiring the ICU level care. And then of course, our older adults are the ones who are dying. So just keep that in mind, young people, that you may get it and you may not be as ill, you may not even require hospitalization, but you can give it to your family member that is older and more vulnerable, and they will suffer the brunt of the ICU and death. So then when we look at it by gender, it's pretty much even in terms of the number of cases between men and women. So we can't blame this on the men. They don't know how to drive, but that's okay. But it's about even between the two. The biggest difference is in ICU beds. So men are requiring more ICU level care. We don't know why. It may be related to comorbidities or other factors in their life, but for some reason, men are requiring more ICU level care. And we'll have more details about that as the pandemic goes forward. Right now, we're still kind of in a search and find phase. And so we're trying to determine all of the causes and reasons that are related to this data. So that will start to come out as the pandemic slows down and we're able to really take a deeper dive and look at these cases. And then if you look at it by race and ethnicity, this is nothing new. We've talked about this for weeks. Looking at all cases, Blacks account for about 22%, Asians 7%, American Indian, Alaska, not much. But then when you get to the other, which is the problem, that's about 13%. And that other could be Black, they could be Asian, they could be Hispanic, we don't know. The unknown and the mixing race is also a large group that we don't know about. They could be in any of these groups. And so what you have with this data is if you have someone that identifies as white and Hispanic, they will be counted in both of these numbers. If they identify as Hispanic only, they will only be counted in these numbers. And so I did speak with the epidemiologists at MDH yesterday, and they are looking at trying to parse this data out a little bit more so that they can give a better understanding of who is really being affected by this pandemic. But what you'll notice is that by and large, 63% of the deaths are in the white population. In the Black population, not as much, Asian, even less. And as you go down, it's less, but then you get to the unknown and missing race, and it's 25%. So we really need to know who these unknown and missing are. And the reason why they're unknown and missing is because this is based on data that the state gets from providers. So if you get tested at your clinic and the test becomes positive, the health department will contact that clinic and they're going to contact you as well. But we do have people who are refusing to give their race. We have people who don't include it on their information. And then we do have people that the state is unable to contact at this time. So we're going to continue to see a fair number of people in this unknown missing race. But hopefully, once the pandemic slows down and they can do a little bit more work, such as sending people out on foot to get information as opposed to trying to contact them via phone or email, we'll be able to get a better idea of what the real numbers are. And then this is my favorite slide. Yes.
Before you move on, I know Rebecca wanted to say something about race,
Okay.
Specifically in COVID-19. Rebecca, did you want to, we kind of saw Adrian's next slide. Is this the appropriate time?
Sure. I just wanted to give a quick update that lets folks know, just a sneak peek of what's coming next, is that the Minnesota Department of Health will be able to show race or ethnicity data as age-adjusted rates in the upcoming weeks. And so as they show age-adjusted rates, that basically will allow us to look at the underlying age distribution if age distribution was the same for all races. And so that will actually show that the deaths amongst Black Minnesotans are much, much higher. And so these charts will more accurately reflect what's going on in Minnesota, probably by the end of the week or early next week as well.
Okay, thank you, Adrian. Did you want to continue?
Yep, thank you, Rebecca.
Thank you, Rebecca.
All right, and so this is the race and ethnicity by population, and I love this one because it really speaks to how it's impacting our community. So if you look at the white population, there are about 4 million white people in Minnesota. They make up 83% of the population in Minnesota. From a case rate standpoint, there are only 177 cases per 100,000 people in Minnesota for the white race. So when you look at Black people, we are only about a little over 300,000. We make up 7% of the total population in Minnesota. However, our case rate is over 3 times, 4 times, 5 times what the white race is. So for the Black community, we are seeing over 1,000 cases per 100,000 people. That is huge. So we have a smaller percentage of the population in Minnesota, but from a cumulative case rate, our rates are higher than white people who make up 83% of the population. So think of it this way. There are way more of them than us, but we have way more disease. That's the easy way to look at it. And this graph clearly depicts that. With Native Hawaiian and Pacific Islanders, it's even higher. They make up about less than 1% of the population, but they have a higher burden of disease, as do our Hispanic neighbors and our Asian neighbors. And so this is a graph that I love because it really shows the true burden of disease in our community versus the 22%, which 22% sounds like not as much until you look at this graph and see how much of the burden of the disease is in our community. And so this will change next week as well, because we do have a lot more cases. We're up to 31,000 cases as of today of COVID, and a little over 1,000 deaths as of this morning. So this graph will change again next week, and those numbers will definitely go up. And then this is just, I'll just zoom through these last ones really quick. This is just looking at where you live and how you got the disease transmitted. The majority of them are in the community. So keep that in mind when we're out this weekend doing our Juneteenth celebrations and gathering with family, that the majority of the cases have been transmitted in the community. And then I'm not going to go into the county data because I know that Dr. Gilliam is going to do a little bit of a deeper dive, but just know that the darker blue areas are where the highest rates of the disease are. And our top 4 players, of course, are Hennepin County with over 10,000 cases, Ramsey with over 4,000, Stearns County with over 2,000, and then an honorable mention to Anoka and Dakota with over 1,000. And I live in Dakota County, so that's a little concerning for me. And then, oops, I went the wrong way. I just wanted to include for everybody, the Minnesota Department of Health is still doing free testing sites. They have 4, the information is here. They are from 12 to 6 on Tuesdays and Wednesdays. They do recommend that you make an appointment though, and the link is there. The link is also at the bottom of the screen for you to go and make your appointment. And we're really trying to focus on those people who participated in large gatherings, such as the protests and the cleanups and the food drives and the donation drives. And so if you participated in those, please go get tested. Whether you're symptomatic or not, you can be tested based on that information. And then also, I would be remiss not to mention that North Point is continuing to do their COVID testing. It is also by appointment, and so you can call that number to schedule your appointment, and you do need to have some of these symptoms to be tested, but call that number, you can schedule your appointment, and you can drive up and get tested. And that is all I have for data today. I know that was a lot, and I'm sure that everybody is scratching their heads going, oh my God, what is she talking about? But again, this data is on the Minnesota Department of Health website. And if you have questions about it, there are people available to discuss it with you, but they are really good about including information on the website that explains the graphs, even for people who don't look at them all the time. So thank you.
Thank you, Adrienne. That was excellent. And between the information that you've shared and also what Rebecca added as our future data, possibly even for our next town hall, is going to show a spike in deaths for Black people. Why is that?
Well, because right now the data is all aggregated. And so it's not really looking at, for instance, when you look at the age 20 to 29 and 30 to 39, we know that those are a higher number of cases. What we don't know is what is the racial mix. And so when I talked to the epidemiologist yesterday, they did tell me that they were looking at that, but they couldn't give me the data because it hasn't been approved yet. So it's actually done. They're just waiting to get approval to share it publicly. But it'd be really interesting to see the racial breakdown of that, because we're fairly certain that, and they wouldn't tell me, but I know, and Rebecca just confirmed it, that the racial breakdown is going to show that there is a higher burden of disease in the Black community than the 22%, which is what's illustrated in the graphs now.
So the data that we can anticipate, let's say for the next town hall, it's not necessarily that we're dying more right now. It's just that the data is more accurate to show who the burden of disease.
Right.
Got it.
Right. And it may show more deaths in our community, because at 80 to 89-year-olds, it will break that out as well. And so when they break that data out by race, we very well could see more deaths in our community.
Wow. Okay. Thank you for that. I want to pivot to Dr. Gilliam, who is going to provide some more data for us, specifically within Hennepin County and possibly even North Minneapolis. So when we talk about, 30% of people who contract COVID are getting it from community. Well, there's been a lot of action lately, and people protesting in response to the murder of George Floyd. Juneteenth is coming up. The weather is nicer. What are you seeing specifically within Hennepin County and within North Minneapolis?
Well, first I'll mention that North Point is testing all comers, even those who are asymptomatic, particularly those who participated in protests and cleanups and other community gatherings, or have had close contact with anyone who was positive, even if you're asymptomatic, in our drive-up testing center, as well as in our clinic itself. Just so we're pretty comparable to the other community sites, and we're here every day. And the drive-up is 1 to 4 every day. But so within the county, I think it's interesting, they have drilled down quite a bit into some of the racial demographic data, as well as those who have been hospitalized. And so what we're seeing is that, so if we know that in the county itself, even though in the state, the Black population makes up about 7% of the state population, within Hennepin County makes up about 13% of the population. And then the confirmed cases of those in the county that are Black is about 30%. So in Hennepin County, the burden of disease is about a little more than twice as much in the Black population as it is with, in terms of our representation of the cases, in terms of representation of our population basis. And it's even a greater disparity in our Latinx community as well, with about 7% in the county and about 20% in terms of the number of people being confirmed positive. And we're also seeing that reflected in the data that we're getting locally at North Point. So at this point, we've tested somewhere between 1,800 and 1,900 people. And And of those tested, 42% of them were Latinx, 31% were Black, 11% were white, but we're seeing 61% positivity in our Latinx community, 27% positivity in our Black community, which gives us an overall kind of positivity rate of 27%. So of all comers, of those who get tested at North Point, so in North Minneapolis, it's about 1 in 4, or a little more, that are turning up as positive. And this is important because we also, as you mentioned, we may not see the burden of disease reflected in death data, but we do see the burden of disease reflected in hospitalization. And what I try to stress to people is that if you're hospitalized for COVID-19, you are very sick. Your oxygen levels are very low, and you are requiring intensive care, even if you're not in an ICU. You're requiring high levels of oxygen. You have a lot of trouble breathing, and it often happens fairly quickly. I'll try to illustrate. I spoke with a gentleman this morning who we diagnosed with COVID-19 here at North Point, and I spoke with him about 2.5 weeks ago to follow up to make sure he was doing okay. And on that day, he said he felt fine. The very next day, he felt worse, so much worse that he went immediately to the ER and was placed on high levels of oxygen and was on the doorstep of being admitted to the ICU, was in the hospital for 2.5 weeks. And I spoke with him this morning. He feels better, but he said that time he spent was something he wouldn't wish on anyone else. So keeping in mind that, and he was in his 30s. So keeping in mind that even if we're not dying at the higher rates, you don't want to get the disease if you can prevent it, and you definitely don't want to end up in the hospital. With all you mentioned the events and things that have been going on, the social unrest, the protests, we aren't seeing a bump in numbers as of yet. The tricky thing with COVID-19 is that 35% of people, based on most recent CDC data, will be asymptomatic carriers. And those asymptomatic carriers are 100% infective. So meaning they can pass along the virus to 100%, just as good as anyone who has a symptom. So with that large number of people who don't have any symptoms at all, and also generally thinking that it was more of a younger population that went to the protests, we actually may see their grandparents and their parents who may present to clinics and hospitals with symptoms of COVID-19 and not the actual person who was protesting. So unless you have a really skilled and detailed epidemiologist, they may not drill backwards to protest as a causative reason for their COVID-19. So it may be difficult to do that contact tracing, but we still have not seen much of a bump in numbers as of yet because we follow them every day. And as Adrian mentioned, our trend in hospitalization and ICU admissions have been going down across the state. So that's a reassuring demographic. But as has been seen in the death data and all the other data, it spikes frequently. So we kind of watch that very closely. So, in the county itself, we find that the concentrations of those who are positive are really it's really in the city of Minneapolis that we have the heaviest burden of disease. And so that's also where we have the highest diversity of people. We often think of comorbidities and the like first, but I like to lift up the fact that a lot of our populations that are getting sick are those who work and are essential workers, and therefore are at higher risk for exposure when they're in the community. And so as we're walking around more often and everyone's not as reliably wearing masks appropriately or and the like, it puts us all at a bit higher risk. Because I often mention to people, I wear my mask for your protection and not necessarily my own. Because the mask that we make at home, if I have a mask on and you have a mask on, we're both protected. If I have a mask on and you don't have a mask on, you're protected, but I'm not. So we have to kind of share that responsibility. And it's very important. and we require for people to come into our building to wear a mask, but it's not, and it's also a requirement in the city of Minneapolis in any public facility, but out in the community when people are potentially in close quarters. So at Juneteenth celebrations, at other kind of protests and other things, wearing masks with everyone will help protect the community, so we are not further burdened by disease when we are, being burdened by other things with respect to kind of human nature and other issues.
Thank you. So let's say someone participated in some of the protests that have happened over the past 2 weeks. They went and got tested, test came back negative. They plan on going out this Friday to participate in a Juneteenth event. Should they then retest because they're potentially going to be exposed to a large number of people? Or like, how often should people be getting tested?
Well, there was a recommendation that everyone who participated in the protests or anything surrounding them be tested, simply because we knew there were thousands of people who did not know each other. So it was impossible for really, for you to know who may have been, who had COVID-19, and also knowing that 35% of people are asymptomatic. That's why that recommendation occurred. Generally, the recommendation would be to monitor yourself for symptoms. Well, I guess let me back up. The first recommendation would be to wear a mask. Second one would be to maintain appropriate distancing. The only people that should be allowed within your bubble of 6 feet are those that you live with, and then maintaining good distancing when you're in public with other folk. And then also understanding that when you're outdoors, the transmissibility of the virus, it decreases quite a bit. It goes up quite a bit more if you're indoors with no moving air, because then the virus is able to spread much easier and kind of hang in the air. But if there's wind and you're outdoors and you're maintaining distances and you're wearing a mask, your risk remains low. But you, once you have a negative test, then you're good. Then unless you develop a symptom, then you should present for repeat testing.
Thank you for that. That question, by the way, was from E.A. Porter, who's watching. We've actually got a lot of great questions coming in the chat right now. Adrian, did you want to vocalize for the people who can't see the chat box the answers to some of those questions? So one of the questions was about if we run out of ICU beds, what happens? Like, does the data reflect the amount of beds available? Like, is the data going to be skewed by how many are available? What happens?
Right. So when we say ICU beds, we're talking about specific beds, but we're also talking about level of care. And so if we run out of actual beds, we would then convert other beds to ICU level care beds. And so the data will continue to reflect those that require ICU level care, even if we run out of actual beds, which that is what happened in New York. They ran out of actual beds in an intensive care unit, and they were forced to take other units and provide ICU level care in those other units. And thanks to New York and Seattle and those places that dealt with this first, Minnesota is well prepared for that to happen if it does. And so we have contingency plans and contingency plans for the contingency plans. And so we hope that we won't run out of ICU level beds, but if we do, we have plans for how to convert other beds so that we can have ICU level care in other areas of the hospitals.
What I can say to add a bit to that is that the period of time when we first went into the stay-at-home orders, that's when all the hospitals really put all their energy and effort into surge planning, which is in preparation for a potential surge and increase in cases, leading to an increase in hospitalizations, which could potentially lead to an increase in ICU use or need. So I know like we work with Hennepin County Medical Center more directly, but they have wings that are prepared to open up as ICU units if they are needed. And the same can be said across the metro. So all the hospital systems have been preparing for a potential surge if it does occur.
Thank you. We have another question from EA Porter, who wants to know, if you're an employer and you plan on reopening soon, can and should employers be requiring that their employees present some type of recent testing documentation to prove that they don't have COVID before coming back to work?
So right now, the Minnesota Department of Health has included in their guidelines that employers do symptom screening for employees, especially in healthcare, but for all employers to consider doing symptom screening. So as long as your employer is doing symptom screening and all employees are wearing masks when they are working and doing hand hygiene, you don't need to be tested before coming back to work unless you're symptomatic. If you are symptomatic, you should be tested to confirm that you do not have COVID, but otherwise you do not need to require testing prior to reopening, but we should respect the universal masking and hand hygiene guidelines for all employees.
And Rebecca, you had some information about an executive order and how employers should be moving forward.
Sure. Under executive, one of the executive orders that is in place by the governor, if you have been working from home, you must continue working from home. And in fact, there's a violation helpline that is up to help employees who are being sent back to the office, even though they have been successfully working from home this whole time. And that number is 651-539-1132, and I'll put it in the chat. But every single day we're sending folks, the Department of Human Rights is staffing that, and we're sending folks home. We're working with employers to get folks home.
Thank you for that. And speaking of working with the governor, you're a part of the Community Resilience and Recovery Group. So can you speak to the work that's being done with the Department of Minnesota to ensure that these racial disparities that we're seeing as it relates to COVID-19 don't continue to exist?
Yeah, so hi everyone. My name is Rebecca Lucero, and I am the Commissioner for the Department of Human Rights. And just to make sure that everyone knows, the Department of Human Rights is Minnesota's very own civil rights enforcement agency. And so we are always working to address areas of discrimination to make sure that everyone can lead lives full of dignity and joy. And of course, COVID-19 is exposing what has always been true, that racism is pervasive and persistent. And this virus is exacerbating Minnesota's racial disparities on many fronts. And so when this virus hit in March, the governor and lieutenant governor very quickly stood up 8 working groups that had to do with everything from figuring out PPE to figuring out daycare. And knowing what we know about the racial impact of COVID-19, the governor and lieutenant governor also stood up this work group, the Community Resiliency and Recovery Work Group. This is an interagency work group, and I have the honor of co-chairing it with the lieutenant governor. And the very first thing that we spent a lot of time on is data. And so I really appreciate the conversations that have been going on here around data, because we actually just launched a dashboard that specifically looks at race and COVID over time. And of course, when you're talking about data, it's really important to know what everyone here has already stressed, that when we're talking about this, we're talking about generations of inequitable healthcare and inequitable poverty rates. People of color have a higher risk of multiple health issues, such as diabetes, heart disease, severe asthma. And these health issues put communities of color and Indigenous communities at higher risk. We're also, of course, talking about how people of color and Indigenous communities work in jobs that have always been essential and are now referred to as such. And there's also the double-edged sword of communities of color being overwhelmingly not able to work from home, and then also laid off at really high rates. Many of the jobs are low-wage jobs and don't have access to adequate healthcare or childcare, compounding existing disparities and harming communities. And of course, communities of color, we live together closely, both because of historical racism that has made it substantially more challenging to buy single-family homes, and also, because we like it. We're multi-generational communities, and that puts us at high risk. So the website is at, COVID-19/data, and it's under the Community Resiliency and Recovery. And there you can see how how race is playing a part in the summary of cases, hospitalization, ICU, and deaths by race and ethnicity. You can also see a breakdown of unemployment and how that's changing over time. Worker characteristics, so that you can see how essential services or businesses such as food processing, nursing homes, supermarkets, warehouses, how that is having a direct impact on Black, Latinx, American Indian communities. And also you can see some information there on the homeless rate. So we're tracking that information over time. And trying to make sure people have this information. And as I kind of noted, this is having a huge, COVID-19 is having a huge impact on Black and brown bodies every single day. And it feels like that story isn't being told because not here, it's being told here today, but like across the board, we're talking about plateaus, we're talking about ICU beds coming down. And I just want to say that is not true for Black and brown bodies, that we are very much still increasing our infection rates, that Black Minnesotans are 7% of the population and 22% of the infection rate. Like it's a crisis in our communities right now. And I'm really concerned as we're talking about dials being turned and plateaus, that we're making invisible and silencing what's actually happening to Black and brown bodies. And so that's something that's incredibly important. So the Community Resiliency and Recovery Group is acting as quickly as possible. So we have a 5-point plan for testing communities of color and Indigenous communities. I'm not going to go into all the details about that right now, but you're seeing the impacts of it. You're seeing the better access to community testing, increased testing at community health clinics, making sure that we are prioritizing testing in industries that have high rates of POCI employees. You're seeing us do a lot more training that centers workers. That's coming out of the Department of Labor, DEED, and Minnesota Department of Human Rights. Instead of it being a technical solution for employers, we're providing oversight, enforcement, and training for employees across the board. You're seeing things like the press conferences being translated into Spanish and Hmong, and us trying to move some funding. There's $1.3 billion moving right now from the federal government to respond to COVID. And we want to make sure we're putting a substantial chunk of that directly to community groups that are led by and for communities of color, who are trusted, who have the relationships, who can act quickly, and who can fill in gaps. There's so many gaps right now. And so those are kind of some of the focuses of the group. And I think that it's just really clear that to build a more equitable world, we have to be willing to name and identify race. And I really appreciate that there was this intentionality from the governor and lieutenant governor to actually name race and address it directly. Yeah, so I'll stop there for now. I can say so much.
Thank you, Rebecca, for sharing that and for all the work that you're doing with the governor and lieutenant governor. I want to take one more question from the audience. I'll ask you one additional question, Rebecca, and then we'll transition to our final panelist, Ms. Tanya, also, so we can start pivoting. We're just on the tipping point of really addressing race as an overarching issue. But before we get to that, Amanda Thomas, hi Amanda, she asked from Facebook, she recently read that the coronavirus requires an acidic environment in the body to thrive. And so one, is that true? And then two, if that is true, what do you suggest that people do at home to release their levels of acidity within their body? I'll direct that to Dr. Gilliam or Ms. Adrienne Thornton.
I'll take that one. I saw the question, so I looked up that article to see where that may have come from. Where the body itself actually requires you to be at a neutral pH, because if you become too acidic, it actually is in opposition to life. So we actually, the body requires balance. And the thought, at least the article I read on WebMD, was that it was actually a true-false thing, and they were saying that was a false assumption about COVID-19 or coronavirus, the thought was that drinking enough water will push the virus into the stomach, into the acidic environment, but that's not the way the virus works. Although it is a good idea to stay well hydrated, you actually want to kind of maintain a good balance. Like everything in life, you want to maintain good balances. So not necessarily eating too many acidic things or too many basic things. So I would say that is actually not a true thing about the virus. But we do know about how it is transmitted through respiratory droplet, through touching the mouth, the eyes, the kind of mucous membranes, touching things with virus on it, and then touching those areas on your body are ways for people to kind of get the virus, and then it just processes through in the way that viruses work. I mean, the issue with it is that no one knows how they will react to it. Most of us do well, but some of us do not. And those of us who do not tend to look like us on this panel, and also to be our grandparents and our parents. So just keeping that in mind.
Got it. Thank you. And thank you, Amanda, for your question. I want to pivot back to the Commissioner, Rebecca Lucero. We know now that COVID-19 is disproportionately impacting Black and Brown people. We also know that we're in this highly racialized moment. America's always been racialized, but we're at what seems like a tipping point in the murder of George Floyd. And so city council members from across the country, including within the city of Minneapolis, are petitioning for racism to be declared a public health crisis as it relates to COVID-19 and as it relates to the disproportionate impacts of African Americans in response to police brutality. What structural changes need to be made so that we can start addressing racism in a more sustainable way?
Yeah, so what I hear underlying all of that is just the real plea that we actually acknowledge, name, and act to make changes around racism, to be anti-racist, to acknowledge the systems that are in place that are actually built to be working exactly as they're designed to work right now. And when you call something a public health crisis, you are requiring intentionality, funding, support around that. And so that is what I'm hearing underneath all of that, that oftentimes racism is this other thing. If we even talk about it at all, we use words like diversity, which are just coded like because we don't actually say race. And so it's just a real hunger to actively center and address racism. So I mean, certainly a lot of folks on this panel and that I'm seeing here use like a policy guideline or a checklist to make sure that they're bringing an anti-racist lens to the work that they're doing. That's one of the changes that we've instituted with the Community Resiliency and Recovery Work Group. We developed an anti-racism policy procedure manual that everyone who's making decisions around funding and policies needs to go through to help make some structural changes. That's a pretty big shift within the governor's office to be implementing and utilizing something like that. It's something that some like nonprofits use and some businesses use, and we're excited to see it being implemented right now. Sorry, my dog's going to start barking a lot right now. Welcome to my living room. And so I think first and foremost, we actually have to be comfortable naming race and talking about race. And then the second thing is, it's been fascinating to watch people feel more comfortable talking about race these past couple of weeks since the killing of George Floyd. And it's been both like, great, this is wonderful, and also like, finally. And so on my best days, I'm on the like, great. And when I'm in a weaker spot, I'm a little bit more angry about how long it's taken to be able to talk about these issues. And so we also just have to act. We've got a lot of people asking a lot of questions, wanting to talk to community. Community has been saying and doing these things for decades, for generations. And so we just got to now act and boldly and start making some changes.
Absolutely. And part of that anger has been channeled into movements for decades, right? And one of the things that we're seeing that is not necessarily new, but is getting a new light shined on it is the idea of defunding the police or abolishing the police or dismantling. There's like 5 different ways that people are naming it, and some of them mean the same thing and some of them don't. So I want to pivot to our final panelist, Ms. Tanya Gladney, who's representing the University of St. Thomas in their Sociology and Criminal Justice program. Thank you for your patience through all of the COVID talk, but the hot button right now is defunding the police. Can you help us understand what does that even mean, and how did we get here?
Hey, thank you. And I just want to say to the panel guests, it's been so informative, the information you've shared about COVID. I'm just immersed into it. So I forgot that I even supposed to speak. So I was just still immersed in all the data that was shared. So thank you so much for that information. It was very helpful. As far as your question, Brittany, yeah, defunding the police, how did we get here? Kind of pivot from Rebecca, a comment about being able to talk about race and having that conversation being more in the forefront. I feel like what has taken place in law enforcement now is that we can finally now address, it has been revealed that the institution of law enforcement historically was not built to include racial voices or our communities of color, right? So with the history of law enforcement and even with a police and society class, it has a very Eurocentric view. So you learn about the development of law enforcement starting as early as the Metropolitan Police Department in London, which was the first to kind of lead this idea of some form of policing in a society. And so fast forward to the United States, similar to London, start having those same conversations, right? What would it look like to have a form of policing in the United States? As early as the form of community, the sheriff, a form of a sheriff department or kinship where the community mainly they pretty much control any type of disorder was taken care of in the community. And these conversations continue over the years, and we have what we call different movements in law enforcement. So you have the political era that highlights a lot of political involvement in policing at its earliest form. It was very, very politically driven. It was very politically corrupt. So fast forward from the political era, it was this idea that we were moving into the reform era, I'd say around the 20s, and we're still reforming, right? But in this particular reform era, we started seeing more of the professionalization of law enforcement. So it's an attempt to professionalize law enforcement by having things such as the code of ethics, by having selection and training, the type of training police officers should receive, how police officers should be selected. And so therefore, the profession has evolved to research, evidence-based, with the focus being on crime control. However, when you take that model and you place it within a society that has a historical relationship in being where racism is at the core, especially with people of color. So when you take that and place it within that context, law enforcement, as sociologists, we would say a social institution. Those social institutions were used as tools to carry out some of the segregated laws that exist in society. So now you have this form of law enforcement within a society that has the history of not including all citizens, right? And so therefore, we have an institution that has been reforming, but that the part of that reform that has excluded race, right? So law enforcement has been reforming for many, many years, but it didn't include race, right? The main focus was on the profession itself, but not race. However, the communities, our communities of color, African-American communities, we have for centuries, for years say that, hey, law enforcement isn't equitable. We don't see how it serves and protect. Anytime there's a survey that's administered, you see that across the board, law enforcement, most citizens would say, yeah, we think they do a great job. But when you look at the demographics, you continually see that people of color do not favorably view law enforcement as serving and protecting. So the conversations about law enforcement and the disparate treatment has taken place over the years. And what we're seeing now is the tipping point of reform, because previous reform did not include race. And that's why I really appreciate Rebecca coming. It's like we're finally, because of technology and video, that society don't have to question if these things are taking place, because that's what has taken place in past years. Citizens of color have always said that police don't treat fairly. They have always said police brutality exists, but it was always doubted, right? So there's no doubt, there's no justification. We saw it in front of us on camera, on video. So there is no denying race. So now the conversation about defunding has led to the conversation of, well, now the community is at the table. I always like to say it's the community table, right? The community is leading the voice on how they want law enforcement to show up in their neighborhoods. And keep in mind, these are not new conversations, right? These are not new conversations. It's just, it's just beautiful to see that the ears are listening now, and that they're at the table saying, this is how we want law enforcement to show up. So to defund the police has always been a conversation to reallocate resources. That's what defund the police means from my perspective, and some of the narratives that I have been part of, is to reallocate resources. Because when you have criminal justice and you have law enforcement in communities that have issues that need to be addressed, it's always done from a criminal justice perspective. It's always done through a criminal justice lens. So that means no matter what call that goes to the police, a law enforcement officer show up. Defunding the police essentially means that maybe a law enforcement officer don't need to show up if it's someone that's in a mental health crisis. Maybe if we put funding more towards employment and program and services in community, we'll have less need for law enforcement, right? Maybe if we address poverty in the communities, we will have less need for law enforcement. So defunding the police is a push to say, we need additional resources in our community, and that in itself will reduce the need for law enforcement. And so that's where I see the conversation on defunding and dismantling. Dismantling means that this current structure, it doesn't work for our communities, right? And it's a structure that we don't want to work within. It doesn't work because that structure did not address racism. So to eliminate the current structure, rebuild a structure that's led by the community who knows what's needed for that community, then it becomes a real partnership between law enforcement and the community. I know it's a winded answer. I can go on and on.
No, it was a winded and very loaded question. So thank you. Thank you for breaking that down. So that's what it means to defund the police, is to reallocate resources and redistribute them to serve our community's needs in a more intentional and specific way. It doesn't necessarily mean that there won't be police anymore. It's just that the way in which people currently are responding to crises could change.
Also, but I do want to address, because I know that there's a lot of different theories and perspectives when it comes to law enforcement. I mean, there are camps of people who would say to completely demolish, we should demolish policing as well. So that perspective is out there. There are some who would say there's no need for policing at all. The community can develop their own format for policing. So that does exist, but I feel like the main narrative is more so to rebuild a structure where you allocate funding to address the different needs of the community that will reduce the need for law enforcement in the community.
Thank you. I want to go back to our chat box here. I see a question from Joan Van Hala. I hope I'm pronouncing that right. It says, do you think a Truth and Reconciliation Commission with the Minneapolis Police Department could be a useful tool for moving forward?
I do. I think that I feel like with any institution, even with the United States, I think it should always be an acknowledgement of past failures, right? I feel like that it won't eliminate some of the historical trauma, but it will put a face on it, right? It will validate that your pain, your trauma was real, and this institution contributed to that, right? So yes, I do.
Thank you. We have another question from Erica Whalen, who says, what does it mean for discussions or reform of law enforcement to include race?
Great question. Well, for one is looking at those policies and procedures. So let's say if you have a community, and when you have a community that is always to go to the word crime. Yes, crime exists in the community, but when you look at how the crime is distributed, you have to look at those laws and policies and how certain procedures may disproportionately affect some communities more so than others. So when you have a procedure like the chokehold, right, and you have to consider, well, if law enforcement tend to be in communities of colors the most because of crime, and it's only because other issues are not being addressed, then we would see that communities of colors are going to be mostly affected by some of these policies and procedures. So to address for race is to look at how we show up, how we communication, right? Understanding that when you're in different communities of color, understanding the culture, understanding what does resistance mean. It may not mean the same in all communities. So when addressing race is to really to do the work and look at those procedures and see how they may be indirectly causing very harmful effect on communities of color that we know won't take place in other communities because they don't have the same need for law enforcement. Yeah.
Thank you. And I know at St. Thomas, there are opportunities for people to become educated, specifically people who are going into law enforcement. Mm-hmm. So from an educational standpoint, as we think about reform and shifting the culture, I love Joan bringing up truth and reconciliation. There has to be an acknowledgement, but within, it comes from all sides, right? So as we are working to train in new officers and to educate them, does there need to be increased racial bias training? Because I would imagine that it exists to some point now. So what do you think is the change that needs to happen from like an educational standpoint?
Right, great question. Well, to address the topic you mentioned about training, absolutely. With the training, yes, cultural awareness and implicit bias training, it exists, and most officers have received some form of it. And I have also helped to provide that training. But we've also had discussions. I've had discussion with police departments on, it's great training for classroom training. As a sociologist, we like to say that's at a micro level, that's in class knowledge. But what does it look like when an officer leaves the classroom? And that's where I feel the gap is as far as the training. It's like you learn the knowledge, you learn about implicit bias, but how do you take that knowledge and use it in the community? Most importantly, how do you assess that this training is being effective in the community? And I feel like that's where the gap is. And as part of this reform, I think assessing more of some of the training or the classroom training that's taking place to follow up and assess to see what it looks like in the community to make sure that it's, what's being learned is effective. As far as officers who are going through the process to be a peace officer in the state of Minnesota, there are certain classes that are required for the Minnesota Post Board, and one of them is a race and ethnicity class or cultural awareness class. And I would say with that class, we offer it at St. Thomas because we have the law enforcement program. I would say that, and I'm sure my colleagues are doing so, but just being true to the content so that when a person enters to the field of law enforcement, they know what systemic racism is. They understand how it works. But it doesn't stop in the classroom. Those type of classes have to continue to be part of the training. And we're seeing that, and in some cases, this is taking place. When I first worked with St. Paul Police Department, it was then called diversity training. You know, over the years, it evolved from diversity training, and I've always shared that this is great that the training is taking place. It's great that the law was passed, that there's a mandate that all police officers in the state of Minnesota have to take at least 16 credits in conflict resolution, crisis intervention, and cultural awareness. And I feel like that was a great move because it allowed police departments to provide this training on a regular basis and not when there's a crisis. Because what we saw in the past, if something took place in the community or if something hit the media, then we're going to have diversity training. Now it's part of all in-service training. So officers get used to having these conversations. They would expect to have these conversations. And I say as a sociologist, this should always be an ongoing training in the police department, because as society evolve and our communities evolve and our different culture and racial backgrounds evolve, policing should know about that and understand how our communities are changing over time as well.
Thank you. We have another question from Cindy Vu, who says, we also see that even if procedures are changed and laws are changed, that officers are still using their militarized trainings upon communities of color. And so she says, we have to continue to see that bias training does not work, and that there needs to be something put in place to hold police accountable for their actions. How can we do better at holding them accountable?
Exactly. And it was kind of from my previous comment, is that we don't see where it's effective because it's not embedded in the accountability piece, right? And that's really the core of our kind of just weeding out officers and behaviors that's not acceptable. It's the accountability piece. It's like holding officers accountable for this action. And that's the core of it. And I totally agree. You can have training, you can learn about implicit bias, but if you don't have the accountability piece, it's almost like, okay, that was some good time, you know, great information, but no accountability when the officer is out in the actual field. So that's really the core of this, accountability. And also leadership. I think leadership has to be very intentional, very intentional on the type of department that they would like to be a part of. Leadership is also an area to hold officers accountable, but we definitely need the laws, because if the law holds the officer accountable, there's some hope.
If I might jump in for a second.
Go ahead, Dr. McCann.
You know, so what we know about kind of training from all fields, really, when we're teaching people new skills or they're learning, affirming old skills, is that didactic or kind of teaching classroom-based training doesn't really stick very well. We're talking in the 5 to 10% range. But when you really start to see things to kind of really embed in a person is when there's coaching involved. Like direct one-to-one coaching. So when I'm out working, I have a person right next to me or over my shoulder say, you did a good job there, but you should have done it differently. You could have done this. So there's kind of direct, kind of right then in that moment coaching. And kind of we figure this out through our work as a trauma-informed clinic, that we have to work with each other closely so that we can be sure that we remain aware and on top of these things that you know, would impact the way we interact with the community. Yeah, so I just wanted to say that.
Right, and I totally agree. And which is back to when it comes to law enforcement, what does that look like when your leader or your coach is the one that's directing the corrupt behavior? And we kind of saw that with what we saw with the death of George Floyd. You had the senior officer who was leading, he was the lead person on this particular call, who was leading what should be done. And in law enforcement, there's you know, that's when you get to that subculture that's embedded into law enforcement. It's like, this is how we do it, despite what we're told in the classroom, despite what's learned in skills. When you get out on the field, you kind of have this subculture where, well, this is how we do it in the street. And then when that subculture is infested throughout the department, then there's this subset way of how we deal with things. And that's where we see the corruption. And that's where the accountability piece is greatly needed to weed out that subcultural way of doing things in law enforcement.
Thank you. You both bring up a really great point about the way in which professionals are trained and how racial bias, although it may be something on paper that our professionals and providers know should not be influencing the way in which they serve our communities, there's a subculture that still allows that. And we see that with police, but we also see that within our medical system. And so I want to ask Dr. Gilliam if, you know, as we talk about the way in which we restructure even the way that the police are trained, do you see any parallels with the way in which the medical system can be restructured also, so that we don't see as much racial bias when it comes to Black people receiving care?
Yes, you know, racism is not relegated to law enforcement. It's baked into the foundations and the structures of the United States. You know, so dismantling racism and kind of white supremacist thinking at its structure is what's needed across the board. We just happen to be looking at law enforcement because it is the most obvious thing to look at right now, but we're having two pandemics at the moment, and the health pandemic that we have going on is a really good representation of how a racist structure, a societal structure, has led to increased illness burden with COVID-19 in these communities. That, you know, through redlining, through kind of economics oppression, through academic oppression, and all kinds of things that put people in communities, in places that put them at higher risk for disease. So yes, to answer your question, it's a both and. You restructure the health care system, but you also need to restructure the academic educational system, restructure the economic system. And I think it is a big task, but it is, as I'm blanking on the person who said it, but the original sin of America is racism. So is race the biggest issue. So we do have to deal with it in all its iterations and not just where we see it most obviously in this moment.
Thank you for that. You know, it makes me wonder, we talk about shifting the training that happens in the education and reforming the system, but within that are still individuals who have operated and benefited from the ideology of white supremacy. And so I think sometimes that's where people get the idea of eradicating these systems altogether. And I'm wondering if eradication, one, is eradication possible? Is that accessible to us in this moment? And two, if it's not, what is the timeline? When can we expect to have law enforcement that we feel like will actually reflect our community, protect and serve? When can we expect to not see as much racial bias within the medical system? Is this like a long-term pipe dream? Is this something we're going to see within our lifetimes? What are we, based on where we're at now and everyone seeming to respond to racial justice in this moment, like Black people just got here, like is the timeline accelerating, or do we still have a long way to go?
I feel like the timeline is accelerating, but I do feel like it is an ongoing process because I definitely feel that there's immediate work that needs to be done, but I don't want it to stop. I don't want it to be a special session, we solve the problem, and we've had decades of trauma, right? So it is my hopes that it is accelerating, but it's not forgotten 2-3 months later or even next year when it's not a high priority for the media. I feel like real reform is to continue this accelerated process. Don't let it slow down. Continue to address issue and always let race be in the forefront. And I feel like that's when we will be hopeful to have real change, because we are, as Rebecca mentioned, that we're now addressing racism, which in my opinion is more hopeful towards real reform and not just conversation about reform, but definitely ongoing. Because if I feel like it's an insult to say this is a quick fix, right? It has to be ongoing in order for it to be a true, authentic commitment to reform.
Thank you. And we have Commissioner Rebecca Lucero back. I want to ask, there is a lawsuit that's currently happening against the Minneapolis Police Department. And the lawsuit is specifically about MPD's excessive force in response to people who are peacefully protesting. So there was a journalist who was seriously injured, as well as another civilian who was protesting peacefully when they were responded to with excessive force. And so that was the prompt for MPD to be receiving this lawsuit. Can you speak on the lawsuit? And is this, in your opinion, the next way in which we should go addressing police brutality is through suing them? Still on mute. Still on mute. Let's see. See if we can get you unmuted there. We may need Alyssa. Are you able to unmute the commissioner?
I'm on it. Just one moment. I think that's quick.
Can you hear me on the phone?
Yes.
Okay. Sorry, I got kicked off and needed to be added back on here via my phone. Let's see. So I think that what I will say is I can't speak to those lawsuits specifically. Those are outside of the purview of our agency, but I do want to just spend a quick second talking about the civil rights violation charge that our agency brought against the city of Minneapolis and Minneapolis Police Department. And what I can speak to is some really quick changes that we've been able to make around enforcement and protests. So, you know, we really quickly identified this, the killing of George Floyd obviously is a civil rights issue. Under the Minnesota Human Rights Act, it is illegal for a police department to discriminate against someone because of their race. And when our department finds a civil rights violation, we seek structural change. And so filed a commissioner's charge against the city of Minneapolis and the Minneapolis Police Department that's looking at the Minneapolis Police Department over the previous 10 years to determine if they've utilized systemic discriminatory practices, the patterns and practices. And we'll be reviewing the training, policies, procedures, practices, unions, budgets, public spending safety across the board. And for some context, this is the first time that the state has launched a civil rights investigation into the systemic discriminatory practices of the state's largest police department in the state. It's also the only investigation surrounding the killings of George Floyd that's focused on the policies and practices and the patterns. It's not about individual people, it is about the system. And so it's a very different kind of conversation that's going on. Most of the time, these, not most of the time, all of the time, these are done by these kind of investigations are done by the Department of Justice, which has a much larger budget and much more staffing. But the Department of Justice is not and will not lead on this under this president. They have not been enforcing consent decrees and have walked away from previous investigations that they had. Chicago is the most analogous to that, where they had an investigation that was completed, and then it was the Attorney General who continued moving forward with the consent decree. And so one of the things that we did really quickly, because we knew we needed to act fast, is we filed a temporary restraining order against the city of Minneapolis. And that was signed in by the judge last week. And there were some quick changes around that, like completely banning the use of neck restraints and chokeholds, regardless of tenure or track, officers must intervene verbally and physically. Failure to do so means that you're treated and disciplined the exact same way as if you were using that excessive force. And when it comes to the question that you asked me specifically about crowd control and how we treat people that are protesting, one of the things that we included as part of the temporary restraining order is that it's the police chief who has to approve the use of crowd control weapons, including chemical agents and rubber bullets and flashbangs, marking rounds during protests and demonstrations. So what was happening before this is that any supervisor could decide to use those. So even if the chief wanted to use de-escalation tactics as a primary means, supervisors could make different decisions. And then the mayor had no oversight over those decisions because the mayor doesn't oversee those supervisors in the same way that the mayor oversees the chief. So it doesn't mean that these things won't happen. It means that they have to be decided by the chief. And what's important is some of these decisions that we put into place as part of the temporary restraining order, which by the way are in place through the entire human rights investigation, are things that they got at, when you think of Ferguson and Baltimore, they were able to secure those changes as part of a consent decree process that took 18 months to 2 years. We made those changes in a week. And so that's what makes me excited about what's next and looking beyond these policies and trainings, which which Tanya was talking about, Tanya was talking about to make sure that we are actually looking at reimagining what public safety means for a community and how we are there holistically supporting community when it comes to everything from housing to education to schools, recognizing how deeply interconnected these are and how racism and it amplifies the issues around all of those. And so I'm excited for what's next with that investigation.
Thank you. And within that investigation, we've had several people in the chat box ask about policing and how most officers don't live within the city that they police. Is that something that you're going to be addressing moving forward?
So two things, the investigation is in its infancy, and so we're going to be looking at all sorts of policies and procedures. That's certainly one of them. And then leaving the investigation aside real quick, that is certainly a topic that's come up repeatedly, and it's being talked about today, yesterday, all night yesterday, within the Senate and the House. And that's something that the House has asked for there to be changes around the residency requirement. It's certainly something that the city of Minneapolis has asked for repeatedly as well. And I testified yesterday in the Senate that said that what they're proposing at this time is really doing a disservice to this moment that we're in. It's really a missed opportunity, and that we'd like for them to look at all of the policies that have been well vetted for decades by community, by police, by advocates, and by legislators, and put together a more bold legislative package to move forward. The governor is certainly ready to support and sign something like that.
Excellent, thank you, and we appreciate you being here. Is there anything else that you want people to know about the work that the Department of Human Rights is currently doing?
Yeah, I think most important that I'd love to make sure to leave with is that that this work has to be centered around community members who have the information and the knowledge. We recognize, like was said repeatedly, this is not a new conversation. The reports and everything is already done, and yet that must be at the center of what we do. And so we have a form up on our website and a phone number that folks can call with any information. We will be doing stakeholder engagement, community listening sessions, talking to public defenders, different advocacy groups. We will certainly be talking to some of the folks who are doing the trainings right now. And so we're going to need everybody's help to do a really robust investigation so that we can do some real transformational change.
Got it. Thank you. I want to ask Tanya one last question from someone from the audience. I believe their name is Danta. Going back to law enforcement and race, is it important to recruit people from the BIPOC community, Black, Indigenous, and other people of color to the field of policing? Do you see that as part of an effective strategy to police reform and eradicating racism from policing?
Oh, absolutely. Absolutely. And speaking of that, and making sure that that can actually happen, part of the restructure and the reform is to also look at the hiring practices because oftentimes, sometimes in conversations, we would hear where a police department would like to increase diversity, but they don't have the candidates, or they don't have the applicants. And so there has been conversations where, what does your hiring process look like? Because the hiring process could actually be weeding out some really good candidates, but based on some of it is the background, and you have to assess to see how much of it may be subjective. Like what may be some of those subjective reasons why a person is being seen as not a good candidate. And so I've always said that, and I always shared that you have to look at the hiring process to ensure that we will have that diversity in the field. And oftentimes that's what I see. And sometimes, especially when I see what students of color, people of color, tend to have a slower rate of getting hired compared to other candidates. And I feel it has a lot to do with the actual hiring process, and to take a closer look at that to make sure that that can be the outcome.
Thank you. And is there anything else that you want to share before we close our conversation?
You know, I feel like this is a moment where that we all have room. We all have an opportunity to contribute towards the reform, sharing experiences or being part of a panel discussion, or being part of some of the, as Rebecca mentioned, the different people she's going to talk to. I feel like this is the time to make sure that this stays on the forefront, that this does not, when it's not visible on the mainstream news, when it's not a main topic, that we continue to still have these conversations to make sure that this accelerated reform does not stop. And that is my request.
Thank you. Dr. Gilliam, I want to give you this last question from an audience member. It says, as we talk about training, I don't hear us talking about the earlier training that comes with the police officer, the doctor, et cetera. So do these people in positions of power even know that they've been a part of a racist system from infancy? And while we're in this pivotal moment of naming the thing and getting more visibility than maybe what we've been able to do in the past, how do these doctors, these officers really face that they have also been a part of perpetuating white supremacy, whether it's within policing or within the medical field?
I think it's been discussed a bit, but you know, in terms of just having a real and honest conversation with ourselves, you know, prior to this moment, I mean, the idea and thought of kind of white supremacy or white privilege has been, you know, a vogue thing to talk about. But I think keeping that in the front of mind, and then helping those who may be in a different place than we are at this moment. In the Black community, we've talked about race forever. It's always an issue. It always has been an issue. And for those who are new partners who are a little late to the party, not giving them side eye, but welcoming them in, and trying to kind of usher them along so they can kind of catch up and get up to speed a little quicker. You know, I think as Commissioner Lucero mentioned, you know, on your good days, you're welcome in open arms, and on a bad day, you know, it gets a little frustrating. But I think overarching, we realize that there are more people who are kind of realizing and kind of opening their eyes and seeing more clearly what is actually going on in the community. You know, the good thing, when I went through medical school, we didn't have these conversations, at least not in the medical school itself. But now I know that in medical schools, they have these racial conversations because we know whether you call it implicit bias or outright racism, it exists. And it affects and impacts how you deliver care as a doctor, how you deliver care as a law enforcement person. Your background, your foundational structures impact all of that. And so you cannot ignore from whence you came, just like we cannot ignore our own history. We cannot discount the history of America and the history of this society, which placed Black, brown, and the other in a lower stature than another.
And before we go, I wanted to ask you, I'm noticing you're sitting in front of a Ron Brown painting. So I know, at least from North Point's perspective, we've got some cultural responsiveness and some community investment happening. Are people able to physically come in and see these awesome paintings, or do they have to wait a little bit longer due to social distancing and COVID-19?
Good eye. Shout out to Ron Brown.
I'm a fan.
He's my favorite artist. This is my personal collection. I brought this in. But yes, we are open. We're open for business. Call first. We see people both in person and over the phone. So if you don't actually need to come in, we try to keep people safe in their homes. But if you need to be seen to kind of monitor your kind of chronic conditions or whatever else, something new is happening, we'll see you. Just give us a call and we'll get that arranged for you. Yeah.
Awesome. Thank you. And I want to close the conversation with Miss Adrienne Thornton, who we opened with and who provided us with all of that awesome data on COVID-19 and where we've been since early March to where we are now. So my question for you, Ms. Thornton, is like, where do we go from here? We already know that we're anticipating data is going to be aggregated in a way that shows really how Black and brown communities are disproportionately being impacted, and also in response to the murder of George Floyd and us just being in the house for so long. Juneteenth is on Friday, and I know, and the weather is beautiful. Where do we go from here? How do we respond to all of this while keeping ourselves safe?
So, it's hard because, like you, if you listen to this town hall, I love the beach and I'm going through some serious beach withdrawal right now. But there are ways to do things. And so I will be participating in the Juneteenth activities. I am a part of Black Nurses Rock, and we are out in the community taking temperatures at different events. And so we'll be doing that for Juneteenth at multiple events. But we'll also be wearing our mask, and we'll also be maintaining our 6 feet of distance from people. Even when we take a temperature, we use a gun and we just put it right up to your forehead, and we try not to get too close to people. We'll also be giving out masks. And so as long as people are doing what they can to maintain those recommendations, everyone should have on a mask. And I know it's beautiful outside. If you're at a gathering outside, if you can maintain your 6 feet of distance, that is the most important recommendation, especially if you're one of those people who just refuses to wear a mask. And we have several of those. Even at the events, we're having to constantly remind people to put on their masks. But if you can at least stay 6 feet from other people, then the risk of transmission is lower. It's not zero. It's never going to be zero. But just do your best to do what the recommendations have suggested, which is frequent hand hygiene, wear your mask, and stay 6 feet apart. And if you're going to be at gatherings, do them outside. I think Dr. Gilliam mentioned earlier that the risk of transmission is lower outside, and that's true. So do an outdoor barbecue instead of having a get-together inside of your house, and try to stay around 10 people. I know the governor has said there can be gatherings of less than 250, and if you ever come to an event and you see me, you will see me dancing around because I am constantly trying to get away from people. And so I am not necessarily comfortable with that unless you're in a really large area where everyone can maintain their distance. But try to keep your gatherings, especially your personal gatherings, as small as possible, and I know people are tired of being in the house and they're tired of being alone, and I understand that. But, I always put it in perspective this way. You have a choice between living and dying. Which one do you choose? We don't know who's going to get COVID and be okay, and who's going to get COVID and get really sick and die. And I'm sorry, I'm not a gambler. I am not risking my life to hang out with my friends. We can meet at the mall or something and walk around the outside at a safe distance. That's about as much as I'm willing to do right now. But, if people just follow the guidelines and wear your mask, do hand hygiene frequently, and maintain your distance, then we should see transmission, go down and decrease.
Thank you. And of course, going to get tested if you start feeling any type of symptoms. So there's the drive-up testing that's available at North Point. Children's has testing available.
It's actually Minnesota Department of Health. We're partnering with them to run their 4 testing sites. So we are a partner to that, and it's free. There's drive up and walk up, depending on where you go. So yeah, you have options for getting tested, and many doctors' offices are doing tests as well if you are symptomatic. So I would call your physician's office first and see if they can offer that to you as well.
Perfect, perfect. And I want to shout out Stella in the comments who said North Point has an excellent collection of artwork. They believe that art happens in healthy communities. So we're going to wrap up this conversation. If you missed a part of the conversation and you want to go back and revisit it, you can check out the African American Leadership Forum Facebook page. This video will also be available later on YouTube. As I mentioned in the beginning, this is part 1 of a 2-part series. So we'll be back here next week for part 2. Not next week, July 1st. So 2 weeks from now at 11:30 a.m. CST. And we're going to take a deeper dive into the COVID-19 data and this concept of defunding the police. Before I go, I want to give a special thanks to the African American Leadership Forum, the Minneapolis Foundation, and North Point Health and Wellness, as well as Children's Minnesota for making this town hall possible. I also want to give a special thanks to North Point, Children's Minnesota, Insight News, the Spokesman Recorder, and Minnesota Community Care for partnering. It's been an honor to share space with you, panelists. Thank you so much for your time and for being here. To all of you watching, thank you for your questions and for staying engaged, and we'll see you next time. Be sure to be good to yourself and keep wearing that mask and practicing your social distancing. Take care.